Okay, can we start now?
Yes, sir, you can start.
Okay. Good evening, friends. Welcome to the PG Track program of Delhi CSI, and we are into the 95th webinar. Today, it's truly a privilege to have respected Madam Manita Saxena with us. Madam is currently Vice Chancellor of the BD Rohtak University. And it has been a great honor for all of us that whenever we have asked, Madam has always politely and kindly agreed to address all our fellows and residents across last couple of years. And we also are truly privileged to have Dr. Sudhoy Kumar sir, who will be moderating this particular session. And along with me, my colleagues, Professor Girish and Professor Sumod are also there in this session. So, ma'am, please, it's my privilege on behalf of Delhi CSI to invite you for this session. And ma'am will be speaking on acute rheumatic fever in 2022, past, present, and future, what fellows must know. Ma'am, over to you, please.
Thank you, Dr. Mohit, and thanks to the team for asking me to speak, and thank you for having this topic of acute rheumatic fever, something that we would have long forgotten. So if I just can share my screen, yeah, thank you. So I'll start my slides. So what topic that Dr. Mohit wanted me to cover is what a fellow must know. So it's more like more of a clinical kind of a presentation where if you are asked questions or if you're faced with a patient of suspected acute rheumatic fever, then what needs to be done and what needs to be, how this patient needs to be managed, and that's how we're going to talk. So this is the scope of my talk. I would be just highlighting the burden of ARS, something that we all feel has actually become less, which it has in some pockets. How do we diagnose it in the recent current era? What are the treatment guidelines and what are the challenges that we face? And then a little bit about prevention and control strategies. So I think, as we all know, acute rheumatic fever results from somehow an autoimmune response to group A streptococci, mostly in the throat, but at times in the skin also. It is a multi-system disease, but what is important about acute rheumatic fever, and that's how the cardiologists are so much into it, is because of its damage to the valve. So all the systems which are affected by rheumatic fever recover completely. It is the heart where the recovery is not complete often and results in so-called rheumatic heart disease. So coming to the burden, it is a big problem in low and middle income countries. In fact, whole of Africa continent and a lot of Latin America continent continues to see new cases of rheumatic fever. It is also seen in some of the developed countries, surprisingly. For example, in some of the indigenous population of Australia, New Zealand, and even USA. As far as heart disease is concerned, if we talk of adults with heart disease, it remains a very frequent cause of heart problem in those less than 25 years. In fact, rheumatic heart disease is the commonest cause of death in those under 40 years of age who are more than 18 years of age. And a large number of cases keep occurring in the children of acute rheumatic fever. It is generally estimated in the report of 2017 that about 320,000 patients die from rheumatic fever and rheumatic heart disease annually, which is a preventable chronic cardiac condition. And I still see some of these deaths that happen in childhood due to acute episode of rheumatic carditis. They come in such a moribund state in gross heart failure with severe acute MR that it's very difficult to do anything for them. So as we know, the phases of rheumatic fever start from group A beta hemolytic streptococcal infection in the throat, leading on to rheumatic fever, which is often presents as polyarthritis and carditis, and then chronicity of the cardiac lesion leads to rheumatic heart disease. The joints totally recover. What is the pathogenesis? We really don't know exactly how it happens, but we know that there is a triad of streptococcal infection, a susceptible host, perhaps genetically susceptible, and environmental factors, especially overcrowding, poor hygiene, and so on, which somehow leads to first episode of rheumatic fever by means of molecular mimicry. And I wouldn't go into the detail. I think there are a lot of papers written on how this all happens and produces acute rheumatic fever. And then once this person gets acute rheumatic fever, the likelihood of another rheumatic fever is quite common after an episode of another infection with strep, and this ultimately leads on to rheumatic heart disease. So rheumatic heart disease, or RF, is quite a classical triad, or epidemiological triad as we call it, of a host, agent, and environment interacting together. I'll just start with this 6-year-old girl who presented to us with class 4 dyspnea for the last 2 weeks. Very short history. She did give history of fever, joint pains about 1.5 months ago. And she was in cross heart failure at that age of 6 years with such a short history. And she had a pansystolic murmur at epic. So the diagnosis is pretty obvious to us that she's suffering from rheumatic heart disease with severe MR. And since the history was short, so we thought that she must be having acute activity with carditis. What is to be done next? Of course, we need to investigate to confirm acute rheumatic fever, do an echocardiography, and then somehow manage this patient. So risk factors of rheumatic fever are younger age group in the school age going 5 to 15, although occasionally you may have patients less than 5 years also, much less common. Equally common in boys and girls, often seen in those where there is overcrowding, poor housing, poverty, lack of awareness, poor access to healthcare, rural location, and we don't know whether there is really any role of undernutrition, genetic susceptibility, but it has been suspected because it is more common in low and middle, or rather low income countries. So classically, it is a disease of social injustice. And in countries like India and many other African countries, there are reports from Ethiopia also that there is not only earlier onset of rheumatic fever, there is also rapid progression leading to very severe mitral stenosis, for example, in childhood or in younger patients, and we call it juvenile mitral stenosis. And similar data has come up from other countries also. How do we diagnose acute rheumatic fever? We all talk about Jones criteria, but it is important to understand that there are no specific diagnostic tests for confirming acute rheumatic fever. It is just a clinical diagnosis where a combination of signs and symptoms and confirmatory lab tests are necessary to make a diagnosis. And this is how it started. Dr. Jones gave the first original criteria in 1944, which you can see were quite related to history, examination, and a little bit of blood investigations. And then there were a lot of modifications, updating, and so on. But echocardiography was not part of it till they were updated in 2015. So the latest Jones criteria that have come is in 2015, which have incorporated echocardiography for the first time. And they've also divided the population into 2 groups, low risk population and moderate and high risk population. And the criteria for the 2 populations are different for this. So one has to use, for India, moderate and high risk criteria to diagnose a case of rheumatic fever. Arthritis and carditis are the most frequent manifestations of acute rheumatic fever. It is believed that carditis is more in younger, arthritis is more in older children, adults. Chorea, we know, is much less common, and other manifestations are even rarer. So this is the report from Circulation 2015, which talks of the most recent criteria for diagnosing rheumatic fever. You can see that there are 2 populations, moderate and high risk and low risk population. The low risk population is practically what it was before. For moderate and high risk population, they have included subclinical carditis, which is diagnosable by echocardiography. Also, they have added monoarthritis. Earlier, it was only polyarthritis and polyarthralgia as major manifestations. Monoarthralgia is, in fact, even a minor manifestation. And you can see that there are criteria for initial diagnosis of rheumatic fever, 2 major or 1 major plus 2 minor, and for even recurrence of rheumatic fever, something that was not mentioned in earlier criteria of Jones, where 2 major or 1 major or 2 minor or even 3 minor criteria could diagnose recurrence of acute rheumatic fever in a patient who already has had one episode. I just want to highlight one specific, of course, there has to be evidence of preceding gas infection. Prolonged PR interval is something that has been discussed in both in low risk population as well as in high risk population as one of the criteria. And I just, wanted the residents and the fellows to look for it, because if you have somebody whom you're suspecting rheumatic fever, patient may be in failure. If there is tachycardia and you get a PR interval which is prolonged, think of it as rheumatic fever or as a minor criteria for rheumatic fever. And this is something we often miss. In fact, we reported a patient with complete heart block who had aortic regurgitation with acute rheumatic fever and presented with a complete heart block, which gradually with steroids, with this treatment, actually improved. We did not have to pace this child, and this child completely improved following treatment and following subsidence of rheumatic fever. So this is something that we don't usually look for, but one has to be looking for these criteria as one of the minor criteria. And as I said, evidence of preceding group A infection has to be there in the form of a positive throat culture. or a raised antibody titer of ASO, or even other like anti-DNase A and anti-DNase B and anti-streptozine, etc. Again, a single titer may not be very important because it may be negative. So if you're strongly suspecting rheumatic fever, then take another sample after few days and see whether there are rising titers of ASO or not. Generally, this is the limit we use, 250 units for adults as the upper limit of normal and 333 units in children. And this is based on very old data. So I think we are still continuing to use it, but we don't have normal data in the current era. Maybe these figures have actually come down, it's possible. Now, of the acute rheumatic fever, it is the carditis which bothers the cardiologist the most. So I'll speak a little bit about carditis. The frequency of carditis in acute rheumatic fever has varied in different series, and these are obviously clinical carditis. So if we look at subclinical, the prevalence or the frequency of carditis may be as close to as 90%, if not more. Generally, it is believed that those who have to develop carditis would do so in the first 2 weeks of rheumatic fever. So if someone has had rheumatic fever and has no evidence of carditis, we can wait and watch. If there is no carditis in 2 weeks, it's unlikely that this patient will develop carditis in that episode. How do we diagnose carditis? It is a clinical diagnosis. The most common murmur is murmur of mitral regurgitation as apical systolic murmur. One can also get a diastolic murmur, which is called as Kerry-Coombs murmur. And of course, AR also could be a manifestation of valvulitis. You may even hear MR and AR. Isolated AR is rather uncommon. Myocarditis is something that not many of us believe in, that it happens. But yes, if there is too much cardiomegaly compared to the degree of mitral regurgitation, or if there is an unexplained heart failure, third heart sound, one can think that there may be some amount of myocardial dysfunction. Again, pericardial rub and pericardial effusion on echocardiography are also features suggestive of carditis. What is important to understand is that pericarditis and myocarditis or heart failure will never occur in the absence of valve lesions, because myocyte damage or myocarditis is not a prominent feature. So if you have somebody presenting as a dilated cardiomyopathy type of picture, please do not make a diagnosis of rheumatic fever or rheumatic carditis, because there has to be a murmur of valvular regurgitation, most often mitral regurgitation. So echocardiography, of course, will tell you how much is the mitral regurgitation, if there's any aortic regurgitation or not. What you can also look for are the beaded appearance of the mitral leaflets. It can also be there in aortic leaflet. Beaded appearance has been described in as many as 1/3 patients of carditis. But if it is not present, it doesn't exclude carditis. There may be a little bit of a prolapse of one of the leaflets, like you have a minor prolapse because of maybe one caudal lengthening or sometimes even caudal rupture, and there may be small amount of pericardial effusion. So one has to really be looking for these subtle features of little pericardial effusion, beaded appearance of the mitral valve or nodules as we call them. And they are easily differentiable from infective endocarditis because they don't show the bizarre motion. And of course, a little bit of prolapse with mitral regurgitation. These could be suggestive of rheumatic carditis in a given patient. Again, echocardiography is not diagnostic. It can only suggest that there is endocarditis, there is rheumatic carditis. Severe mitral regurgitation, often the examiners like to ask what is the cause of mitral regurgitation. So these are the causes that are listed here. Majority of patients will have everything. They'll have a dilatation of annulus, they would have elongation of chordae, they will also have a little bit of prolapse of the anterior leaflet, but rarely you may get such a severe prolapse that there is actually flail anterior mitral leaflet. Lot of, in the past, a lot of people used to think that once it is flail, it is not infective, it is not rheumatic carditis, it is infective endocarditis. But we have seen a number of patients who are presenting, especially children who present with fulminant kind of carditis, rheumatic carditis, that they can present with flail, totally flail anterior mitral leaflets, although I must say it is a rare phenomenon. Subclinical carditis, which has been put in the recent Jones criteria of 2015, is only diagnosed by echocardiography. There are no murmurs, but what you see is little bit of mitral regurgitation, which is more than trivial. And these are the criteria that have been defined to differentiate pathological mitral regurgitation, which may be there in many of us, from physiological MR, which is present in many of us, to differentiate it from pathological mitral regurgitation, that you should have a jet length of more than 2 centimeters. It should be visible in 2 planes. Peak velocity of the mitral regurg jet should be more than 3, and at least one signal should be holosystolic on Doppler. And for AR, it will be similarly holodiastolic. Then we can say that this is pathological. Of course, in addition, you can have thickening of the valve leaflets as a morphologic feature suggestive of subclinical carditis. Another point to be highlighted is that those who have mild carditis are unlikely to develop rheumatic heart disease. That means the severer is the carditis, more likely patient is going to end up with chronic rheumatic heart disease. And therefore, patients who have no carditis or mild carditis are those who are likely to recover at 1 year or within 6 months. And these are the patients who will probably do very well in the long run. But if severe carditis is there, you can almost be certain that this patient will end up having severe or at least some rheumatic heart disease. Coming to polyarthritis, this is seen in about 75%, more common in older children, adolescents, and even adults. It classically is migratory, asymmetric, non-suppurative, usually involves large joints. Even the spines and cervical joint can also be involved. There is so much tenderness and pain that the child or the patient is just not able to walk. In fact, it is out of proportion to the swelling or the redness that you see on examination. And there is such a dramatic response with aspirin that it is almost diagnostic of rheumatic arthralgia or arthritis. By just one tablet of aspirin can do wonders for these patients. It tends to heal without any deformities left behind. Sydenham's chorea is much rarer, seen in 10 or 15% of cases. It is usually not seen at the stage when there is acute carditis. It's a rather delayed manifestation, often occurs as an isolated manifestation. More common in females. There could be even hemichorea. In fact, 20% of patients can have just chorea of half of the body. And as I said, it is much later manifestation of acute rheumatic fever. It is characterized by involuntary and purposeless movements of the skeletal muscles, and may be associated with weakness, hypotonia, and even emotional instability. What is problematic about Sydenham chorea is that it can really last long, several months sometimes, and usually is self-limiting. One has to, of course, give medications during this time to make the patient feel a little better. Skin manifestations, subcutaneous nodules, not so often seen, but why I want to show is that you have to really be looking for them. Patients will never come and say that they've got a subcutaneous nodule. If you're suspecting rheumatic fever, please examine the patients on the bony surfaces, examine over the spine, and look for these painless swelling, which are firm and movable under the skin. So these are usually totally asymptomatic. The important thing is that if there are subcutaneous nodules, it invariably means acute carditis, and therefore their diagnosis or their detection is of importance. This is something that I've seen in only one case, Erytrea Marginatum. It is generally believed that in India, especially dark-skinned people, you may not be able to see it very well. But again, you have to really be looking for it. But I think it's much rarer than described in the Western population. Some other features that we often see in our patient is epistaxis. If a patient has rheumatic fever or rheumatic heart disease or a murmur and is having epistaxis, please think about active carditis. Rarely they may present with abdominal pain also, even rheumatic pneumonia. And these are important features because we tend to give them steroids, and steroids can actually aggravate if there is a real infective pneumonia. So what are the challenges? As I said, there is no diagnostic test. Therefore, whatever guidelines are there, they are useful, they are very directive, but they cannot substitute patients' experience and common sense. There are a lot of other conditions that will fulfill Jones criteria, especially those who have only joint pains. And diagnosis of recurrences can also be challenging. However, recurrences should be suspected if there is worsening of previous valvular lesion. I would say recent onset unexplained heart failure with a murmur, especially in young people, must be thought of as rheumatic fever. Rub is almost always diagnostic of rheumatic fever, and then we can investigate them and look for the ASO titer. We analyze our data of 126 children who had acute rheumatic fever in a registry that we were maintaining. And again, we realized that not many of them were actually fulfilling the so-called Jones criteria, although it was left to the discretion of the cardiologist to decide whether there is activity or not. But recent unexplained worsening of dyspnea, younger age, significant mitral regurgitation, nodules on echocardiography, and elevated CRP suggested that these patients had active rheumatic carditis. And based on that paper, we actually wrote another paper where we devised a scoring system to diagnose acute rheumatic fever with carditis. This was recently published, and we gave scores to all these variables that you can see on age, on NYHA class, on the degree of mitral regurgitation, nodules present on echo or not, ESR, ASO, and so on. Total score max could be 13. And we realize that if there is a score of 5 or more, the likelihood of activity is much higher with a sensitivity of 76%, specificity of 79%. So these are just some of the features that may help us to make a diagnosis of rheumatic fever if the diagnosis is not really coming up with typical classical Jones criteria. So how do we manage? It is absolutely a symptomatic treatment, and it will not alter the course of the disease, and that is something that we need to understand. Principles of treatment are primarily eradicating the infection, streptococcal infection with antibiotics. The commonest we use is penicillin. Symptomatic treatment of whatever clinical manifestations are there, polyarthritis, subcutaneous nodules, and so on. Treatment of heart failure, that is something where cardiologists are of obviously significance, because heart failure patients would be coming to us, and many of them, in fact, when they get into heart failure, only report to cardiologists. Till then, they've been seen by pediatricians mostly. So if there is heart failure, it has to be treated with conventional medications of diuretics, vasodilators, and so on. But what we have found in our experience very useful is the sodium nitroprusside infusion. So those who are present with acute mitral regurgitation, class 4 symptomatic, sometimes echo showing flail mitral valve, we can use sodium nitroprusside very carefully, because this usually helps to stabilize the patients. And one obviously has to monitor the blood pressure very, very carefully, because these are sick patients and one doesn't want them to develop hypotension. Therefore, often I would put in an arterial line when we are giving SNP infusion, because these children are not very small, and putting an arterial line is not a big issue. But at least you can titrate the dose of sodium nitroprusside, and you should try and give the max tolerated dose. And as we know that after about 48 hours, SNP tends to lose its significance or its benefit. Therefore, it is better to go to the highest tolerable dose as soon as you can. And for that, having an arterial pressure monitoring is very useful. Role of bed rest or limitation of activity needs to be individualized. And of course, secondary prophylaxis for prevention of recurrence has to be, this is the right time to start, because patients and the families are quite motivated at this point in time. And rarely, if we are not able to control failure, then one may have to resort to valve surgery, something that you don't want to do it. So as far as bed rest is concerned, it is quite variable. I remember 20 years, 30 years ago, we used to say that the child should stay in bed, should not get up, should not go out to play. Now we've started telling the child can stay at home, may not go to school to avoid sporting activities, but then at home he can move around, he can go to the washroom, he can walk within the premises of the house. Strict bed rest is perhaps not recommended in any case. However, those who have congestive heart failure, those who have significant cardiomegaly, it is better to let them rest for the first 3 to 4 weeks and then gradually allow activities. But again, not strict bed rest, but just limitation of activity. This table is telling us about the treatment and the drugs that we use for specifically for major manifestations. Like for carditis, we would be using steroids if it is severe. However, if it is mild, one can go even with aspirin. But I think patients presenting to our centers, your centers, I think those who are in tertiary care center would mostly be having moderate or severe carditis, and they would end up having steroids. Many a times I've tried to use aspirin in some patients, and I've ended up shifting them to steroids. So I quite like to start steroids in this dose of about 2 mg per kg per day. You can give in 2 divided doses if it's a child, or a single dose if it's a relatively older child or an adult, and tend to continue for about 3 weeks or so, and then start tapering it off over the next 9 weeks, so that we have covered a total period of 10 to 12 weeks, which is usually the duration of active carditis. There are some people who might give aspirin towards the tapering side when the tapering of steroid is being done, but generally we don't do that, and we just continue with steroids and gradually taper it off without adding aspirin to it. Of course, one has to give all the precautions of not taking it empty stomach. Very often we start them also on PPIs, Pen 40 or even ranitidine we used to give earlier, because this can quite be troublesome for the causing gastritis. For polyarthritis, as I said, aspirin can do wonders, and therefore that is the drug we use. But the dose that has to be used is quite high, and therefore a lot of people have started to go towards non-steroidal and anti-inflammatory drugs like naproxen or brufen, so as to reduce the toxicity of aspirin. Chorea, which is a later manifestation, very chronic, very protracted. One can continue to use these medications. They may be helpful symptomatically, but it takes time. And I think the patients and the parents have to be little told or counseled that this is something that will take time, and therefore they should not get too worried. It could take months, sometimes 3 to 6 months also. The recently published Australian guidelines have quite categorically preferred naproxen and ibuprofen over aspirin as the first-line therapy for children who present with joint pains. However, in our setup, we are still continuing to use mostly acetyl salicylic acid.
There was just one doubt regarding that aspirin dosage. The previous slide, madam.
Yes, sir, it should be per kg actually.
Yeah. I think
by mistake.
Because for the student, they may just take this down and will quote madam. Okay, sorry, madam. Go ahead.
No, that's okay. I'm glad you pointed it out. In fact, we often use about 50 mg per kg, although the books write 75 to 100, but we are usually using 50 mg per kg per day in 3 or 4 doses. But this is what the textbooks write, that you have to use a very high dose. And that is perhaps the reason why people have started to go on other NSAIDs rather than aspirin. This is again a report from New Zealand, actually, where they see a lot of these Maoris with severe carditis, children. And here, Dr. Wilson has published this paper where 2 patients who had very protracted course, in fact, they were given 3 times prednisolone. Every time the prednisolone would be tapered, an aspirin will be added, and they will just go back and start having activity. So in these 2 patients, one was a 12 and another was a 14-year-old, their group has used HCQ in the dose of 5 mg per kg per day. And of course, it has been given with the steroids, but relatively lower doses of steroids. And in both these patients, they could reduce their ESR and their other inflammatory markers, including pericarditis, etc. Having said that, despite this, one patient who was a 12-year-old child did undergo a surgery because his mitral regurgitation was very severe and his left ventricle was dilating, but at least he became stable and the inflammatory markers had stabilized. So they are also recommending that HCQ can be used in cases where the steroid themselves alone are, whenever you stop steroids and the activity comes back or the patient becomes sick again. So HCQ can be added in such patients, not the first line, but after 2 or 3 courses of steroids. Coming to valve surgery, again, it's something that the surgeons don't want to do, we don't want to send, but there are extreme situations where one has to resort to surgery, and that could be totally flail mitral valve. If you have this kind of a mitral leaflet, interior mitral leaflet, you can see here, I think no amount of medical therapy is going to help this patient. We would still want to wait till the active parameters of ESR, CRP, etc. have stabilized. However, there are patients who would be so sick, they'll be on ventilator, they'll be on SNP drip, that they cannot be stabilized. And these are the patients who will have to send for surgery. Having said that, I think in my entire career, I have only pushed 4 patients for surgery during the active carditis phase. 3 of them have made it. So surgery is feasible. Nobody wants to do it. But if one ends up doing, then it will be better to replace the valve rather than repair, because repair can be very difficult in this inflamed tissues. And valve replacement is probably going to have a better long-term durability than a repair. It is also mentioned that surgery may just lead to quick effervescence, and patients' steroid course can also be actually curtailed. However, mortality is not very low in this situation. So it should be considered in life-threatening cases which are not responding adequately to medical means. Finally, it is the prevention. As we say that rheumatic fever, rheumatic heart disease is the only cardiac condition that is preventable. Unfortunately, we still have it ongoing in many countries. So this is where we talk about primordial prevention, primary prevention, secondary, tertiary, and so on. So when we say primordial prevention, we should ideally be using vaccine, which we don't have, although a lot of research has gone on vaccine, and it's a topic in itself, which we are not going to discuss today. But there are issues with vaccine. What we usually believe is in primary, secondary, and tertiary prevention again is quite late, because tertiary prevention means preventing complications and death, which means simply treating these patients with diuretics, with antiarrhythmics, and so on. So let's come to primary prevention of acute rheumatic fever. What it means is that you recognize the bacterial pharyngitis and you treat it with antibiotics. And pharyngitis is such a common disease in school-going children that it's very difficult to say that which patient should get antibiotic. Therefore, how to recognize that this child has bacterial pharyngitis and not viral. So there needs to be awareness programs in schools and communities. I think even many of our healthcare workers do not understand that there is a relationship between sore throat and heart disease. It's an information that is often missing. So we need to train the frontline health workers and of course make sure that there is enough supply of antibiotics. There have been some instances where people are talked of giving antibiotic to all sore throats, whether viral or bacterial. But I think we all know that that will be misusing antibiotics and therefore it's not an advisable approach. What are the challenges to primary prevention? Many patients of acute rheumatic fever will not give you a history of sore throat in the previous 2 or 3 weeks. And therefore, because sore throat is such a common thing that you tend to forget. Also, it is difficult to differentiate bacterial from viral sore throat based on history alone or clinical examination alone. And therefore, we also know that often it is viral sore throat. In fact, of 100 sore throats, about 75 to 80% are viral. Only 20% are likely to be bacterial sore throat. In some communities, it may be even less than 20%. So which one is bacterial, which requires antibiotic, is something that we need to see. And doing a throat culture is the answer. But then we all know that throat culture is not available everywhere. And of course, it takes time for the result to come. About 50% of rheumatic heart disease patients will not even give you a history of rheumatic fever. So forget about sore throat, even rheumatic fever history may not be there. So primary prevention sounds theoretically feasible, but is practically impossible to achieve at the community level. So what do? We should try and differentiate bacterial from viral sore throat. And for this, there was a paper that came in 1998, which we are following now, where they have again given scores for the various parameters that one comes with. For example, high fever. Mild fever you can get in viral sore throat, but high fever more than 38 is unlikely to be viral. Absence of cough is another very important feature. You know, the viral sore throat will have coryza and cough, but there is a lot of sore throat, there is pain on swallowing, there is tonsillar enlargement, but they don't cough much in bacterial sore throat. Tender anterior cervical lymphadenopathy, tonsillar swelling or tonsillar exudate that one can see on examination, younger age group. So these are some of the scores that can be given to patients when they present with history of sore throat. And it is generally said that if the score is 4 out of this total of 5, if the score is 4, then it is likely that this patient has bacterial sore throat and therefore should be treated with antibiotics. I would say without even doing any culture, this patient should get antibiotics. However, if the score is 1, no antibiotics are required, not even culture is required according to this paper. But the patients who are falling into score 2 and 3 are the ones where we are not sure whether they have bacterial sore throat or not. And those are the patients where you can take decision either way, but it will be best to culture them if we want to be very sure. But definitely if the score is 4, then one can go ahead and give them antibiotics. So what are the antibiotics that we give? Generally, the recommendation from India is to start oral penicillin V, something that we find very difficult to get, but this is what is recommended. And IM penicillin for those who you think will not complete the course for 10 days, because the recommendation is for 10 days. But if we believe that they are not going to complete the course in 10 days, it is better to give them injection and be done with, because just one injection is what is required. Those and some of the patients are also on amoxicillin simply because penicillin is not available. Cefadroxil, cephalexin, etc. can be used in those if there is history of penicillin allergy. Erythromycin, I would say, not really cefadroxil, cephalexin, but erythromycin can be used in those if there is history of penicillin allergy. Sulfonamides and tetracycline are not recommended for streptococcus sore throat. Having said that, again, the Australian guidelines have recommended co-trimethazole, which is a combination of sulfonamide with trimethoprim. And here, the Australian guidelines say that use BPG as the first line. So give injectable penicillin as the first or most importantly to patients who present with sore throat where you suspect streptococcus sore throat. They've also given dosing for very young children less than 10 kg because they do see rheumatic fever in 3-year and 4-year-old also, and therefore they've given dosing for this. So this is what they recommend. Oral penicillin is the next best, whereas in India we usually say oral penicillin first and then injection. And of course, amoxicillin is another drug that we often use in our patients, but they're also recommending azithromycin, which is something which is very, very effective against streptococcus infection. Now, coming to secondary prophylaxis, which is usually the one that we believe in, which is usually the one that we practice. It is the most cost-effective option. Again, we often use long-acting penicillin rather than everyday erythromycin. And if we use efficiently secondary prevention program, then there is a study which has shown that this is the cheapest way you can take care of rheumatic heart disease. At least you can stop the progression of rheumatic heart disease. And this is the study from New Zealand. It also reduces the severity of rheumatic heart disease. In fact, there are 3 studies which have talked about that there is regression of rheumatic heart disease 50 to 70%, by 50% to 70% if patient is very adherent to penicillin prophylaxis. So penicillin prophylaxis, secondary prevention, is something that we must practice, however mild carditis or mild rheumatic heart disease it may be, but should emphasize the importance of secondary prophylaxis for the parents. Again, there has been some debate whether we should use it 3 weekly or 4 weekly, the benzathine penicillin, but at least in endemic countries like ours, we've been practicing 3 weekly simply for the fact that the levels of penicillin go down in the 4th week. And this is one study which shows that the recurrences of rheumatic fever were more if you were using 4 weekly compared to that if you were using 3 weekly. So this is something that we continue to practice as 3 weekly, but I'm sure if rheumatic fever becomes less and less common in some of the pockets of India, we could even go for 4 weekly prophylaxis. Now we talk of penicillin all the time. We believe that penicillin is the backbone of prophylactic programs for rheumatic heart disease, but then we all know that there have been a lot of issues about availability of penicillin. Fortunately, it's become available now, but oral is still very difficult to get. And then there is a huge fear of allergic reaction. I'm not sure how true it is. At least in children, it's a very uncommon situation. I have seen those who come with history of allergy, and we take them to the ward, we take all the precautions and give them injectable penicillin in the ward, and many of them just turned out to be a little bit of skin rash here and there, and not really penicillin allergic. So we've been using penicillin, I would say practically in everyone. I think in our own data, out of 150 children or something, 6 or 7 were the ones where we ended up giving erythromycin. But penicillin was useful in majority simply because you give 3 weekly injections and you are done. But for erythromycin, you have to just keep taking the tablet every day, and always patients used to tend to forget. Also, there are a lot of gastric side effects of oral erythromycin. Also, generally, we don't pay much attention to pain reducing mechanism, and therefore a lot of children are very fearful of this injection, which is actually quite painful because it is not a water soluble injection. The other thing that we faced is that not many companies are ready to produce penicillin because the government has fixed the price of penicillin as an essential drug to some 14 or 7 rupees or something, and the profit of margin is very narrow, and therefore I have spoken to many companies and most of them are not very happy producing penicillin. They would rather produce antibiotics, which are much more expensive, and that is what happens, that we end up using high-end antibiotic for a simple sore throat. How do we improve adherence? Registry-based tracking and surveillance has been proven to improve adherence to penicillin prophylaxis. We have also done a paper on that, and there are a lot of other papers in the literature. And then, of course, there are various other measures. I think what works best is use of 1% lidocaine as a diluent. And this is what we do often, and that really helps in reducing the pain of penicillin injection. Unfortunately, many of the clinics don't follow any of these measures. So how do we advise them about secondary prophylaxis? These are the drugs that are often used. Again, as I said, BPG is the drug that we should use, and this is the dose, 12 lakh units for adults and 6 lakh units. We usually give in children every 14 days, but there are recommendations for 21 days, even for children in many of the Western countries. And in fact, from India also, there are some guidelines which say it can be given 3 weekly, even for children. Then we can also go for oral penicillin if required, but again, it is something that one has to take every day, and therefore it's not a very good situation where one tends to forget. And I think there are ample data to say that oral penicillin is inferior to injectable penicillin as far as recurrence of rheumatic fever is concerned. Erythromycin is for those who have allergy to penicillin. There is actually no data on azithromycin cephaloxime, but I've heard azithromycin being used in many of the conferences, but I did not see any publication on azithromycin being used as secondary prophylaxis. The next question is, how long should we use it? It is generally said that if there is no cardiac examination, echo is normal, one could just use it for 5 years after the last episode or until the age of 18. However, if there has been carditis, it is better to use it for 10 years or till the age of 25. For severe carditis and those who have had one valve surgery, for example, there is mitral valve replacement done, it is better to continue up to 40 years of age. One data from south of India says 26 years, but generally we are following 40 years of age as the cutoff. WHO still continues to say lifelong, but I think that's an overkill. Even Australian guidelines talk about 40 years now. So I'm just going to finish here and just going to show that despite all these challenges in diagnosis and treatment and prevention, I think where there is a will, there is a way. And this is a country which is our neighbor, where there has been a marked decline in rheumatic fever and rheumatic heart disease, as you can see. And in fact, it has been published again in 2015, where they found no increase in the incidence of rheumatic fever or prevalence of rheumatic heart disease. So they continue to have very low levels of rheumatic fever, rheumatic heart disease. And Kerala is another example where you hardly see rheumatic fever now. I'm sure even rheumatic heart disease numbers would have gone down significantly over the years in our own country, in the state of Kerala. On the other hand, we have Bihar, where hotspots, where even young children are coming with acute rheumatic fever. So a comprehensive control program is something that will give us this success, which has to be a combination of many factors, including primary prophylaxis with treatment of bacterial sore throat, aggressive secondary prevention strategies, training of frontline health providers to make them understand that sore throat is not benign, large-scale education of the community, of the doctors, of the physicians, of the nurses about rheumatic fever and rheumatic heart disease. Unfortunately, when patients come to us, they are at a stage of RHD and not much can be done for them. And of course, active epidemiological surveillance for those patients. Thank you very much. So I will just finish and summarize here that acute rheumatic fever has been and continues to be a public health problem in many parts of the world and in some pockets of India. It primarily affects children and young adults. There is no specific symptom, sign, or a lab test that is diagnostic. One has to use the clinical judgment and Jones criteria as guidelines. Early diagnosis and milder carditis will definitely help in reducing the development of chronic rheumatic heart disease. Treatment is largely asymptomatic. Valve replacement can be considered, should be considered in very fulminant cases, and meticulous secondary prevention is necessary for preventing recurrences. And this is the future where we all, if unite and do a comprehensive program like it has been done in Bangladesh and some of the other islands that I didn't talk about, we can put an end to this disease, which is largely preventable. Thank you so much.
I think sir, over the last 35 minutes, we have summarized what I have learned from 1971 to 2nd June of 2022 and more. Many things, especially that scoring system, all those things. So many things you have added. It was a wonderful presentation. I have certain points to discuss, but for the postgraduates, the myocarditis is the issue which is likely to be asked. Am I right, madam? Myocarditis, why there is no real myocarditis? That's a question which will be asked. What I know is, despite this heart failure and mitral regurgitation, we have found that in echocardiogram, the myocardial thickness is preserved, the myocardium is contracting well, the ejection fraction is still more than 70%. So that means the myocardial component. Second thing, the troponin is only marginally, not significantly elevated. And the strain pattern evaluation of the strain, myocardial strain pattern has not shown. Am I right?
Yes.
These are the things which I know.
Absolutely. Yeah. Even biopsy has been done.
Yeah, biopsy has been done.
Again, it did not show myocardial damage.
Yeah, these are the things I did. Then second thing is another thing in carditis. When a patient comes with myocarditis or whatever it is, we may have the differential diagnosis of viral myocarditis versus rheumatic fever. If there is no murmur, it is unlikely to be rheumatic.
Absolutely.
I think that is one thing which is very useful. And if you can easily hear a mitral regurgitation murmur, it is rheumatic. Because in viral, even if there is a murmur, because of the severe LV systolic dysfunction and high LA pressure, the murmur will be less impressive. Whereas in there is another point, There is in rheumatic carditis, if murmur will be very prominent, MR murmur will be very prominent. That also is a point strongly favoring the lack of significant myocarditis. We'll always use significant because we're not sure.
Yeah.
Then, as Madam has said, Madam has shown a picture of PML prolapse or flail. But I think if there is in rheumatic, I think in one of the slides you have shown, AML prolapse is much more common. And in rheumatic heart disease, or when you get isolated mitral regurgitation, chronic heart disease, if there is prolapse of the AML, look for rheumatic for other pathological features also, compared to a simple PML prolapse. So when you get mitral prolapse, we are with mitral regurgitation echocardiographically, many times we may go for myxomatous degeneration. But I think we have to put effort to see that this is really myxomatous and not really rheumatic, because the management differs. And that may be the reason. One of the things which I have shown, which is there is 50, when a long-term penicillin was given, there was a 50 to 70% reduction in the regression of valvular heart disease or chronic heart disease. I think probably because those who did not or who are not receiving long-term penicillin, they are getting subclinical recurrent carditis. That may be the reason for that. That's my thought process. I have not read that article. Then regarding certain doubts I have, Madam, before can I or the audience doubts from the students?
Please go ahead, sir. Please go ahead.
Okay. The surgical mortality for mitral valve replacement during acute phase is only 5%. That is something which is disturbing me. Because there's a very high risk case which you are taking for surgery. There is an acute inflammation. Probably that also may suggest that the myocardium is okay. Because otherwise, 5% in a very high risk, because obviously you are taking the child for valve replacement only if the child is in resistant heart failure with severe MR. That was a little not very happy, but it is a pleasant data. Regarding HCQ, the problem with the presentation is not with Madam. The students may get a feeling that they can start HCQ. That should not, because there are only 2 patients. And one patient, I think, did not improve or something happened. So that is purely academic for research or keeping in mind. But sometimes what happens is they may quote Madam and start using HCQ. Now this happens, Madam. I have seen that. Some of the students starting very funny things and say that I have heard this in this conference by such a reputed person. These are some of the comments. Madam, you can discuss about clinically how you can say it is a mild carditis or severe carditis clinically and echocardiographically, because decision making is different. Madam, I have a doubt. In one of the slides, you said that in children, 2 weekly versus 3 weekly. That was one of the slides. 2 weekly is recommended?
So what I was going to say is that if you read in the books, it will be 3 weekly. It will be 3 weekly for children as well as adults. But what we have been following here, and again, I would quote my mentor and teacher, Dr. Tandon, he always used to say that if you're using 6 lakh unit, use it 2 weekly. So what we are following at AIMS all along has been, I mean, I wouldn't say everybody, but most of us follow 2 weekly regime if we are using 6 lakhs in children, and 3 weekly if we are using 1.2 mega unit or 12 lakhs.
Okay, Madam. Now, regarding one doubt, which I have asked my teachers, students have asked me, in acute rheumatic fever, what is the, because prolongation of PR rule is not taken as an evidence of carditis.
No.
Why? That was a question. So, Madam, I am not asking you. The question which I have asked, students have asked. The answer which was given was, it is vagal activity. But that is not applicable because there is already sinus tachycardia. So do you have some explanation for that? No carditis, sinus tachycardia, prolongation of the PR.
Right. So you're absolutely right. This is usually the explanation given that there is a little bit of vagotonia. Now, sinus tachycardia is there, but if there was not increased vagal tone, then maybe the heart rate would have been even faster. That is what the explanation is given. So fine. Prolonged PR is not carditis. Prolonged PR would just mean acute rheumatic fever. But again, as cardiology,
the question they asked, you have myocarditis, you have sinus tachycardia, there is a sympathetic discharge. Even in acute rheumatic fever, the heart rate is disproportionately fast. That is one of the things. There is
Right.
temperature is 100, heart rate may be 120, indicating that there is carditis.
Yes.
And that is a response to rheumatic fever as well as this thing. Otherwise, why should there be carditis? These
Right.
were questions asked by intelligent students. And
Yes.
I also asked the question. I was not satisfied with the answer, but I continued to repeat that answer.
Right.
I'd say that this is the hypothesis. I am also not
Yes.
happy with that. That's my one doubt. Second thing, one of the ECGs which madam has shown of that when you are talking about AV block, there was an ECG with a higher grade of block going to complete heart block, and that showed LBB also. Am I right?
There was?
LBB also.
Blood bundle.
Yes, it had a broad QRS. Absolutely.
Yeah,
You're
yeah.
absolutely right.
That
In
means
fact, this is the
that-
patient we reported. It's a very
Yeah.
rare case. So complete heart block is rarely reported, but it is with narrow QRS mostly. This particular patient has a broad QRS. You're absolutely right.
If somebody asked, then is it not carditis? Because if there is an inflammation of the AV node, it is an infrasin conduct system, or the white QRS could be intraventricular conduction delay.
Right,
So
right.
somebody, I'm telling an intelligent or a very studious student can raise this doubt. And if that candidate raise that doubt, I will give bonus mark for that because I don't know the answer for that. These are some of the things I have. I think that's all what I have. But really enjoyed, madam.
Thank
The
you.
the latest, all the recommendations in 35 minutes time. It is wonderful, madam. I enjoyed the same pattern when you presented VSD in the PG teaching program. We used to meet in Chennai.
Chennai,
And
yes.
madam's discussion on VSD, pulmonary hypertension, I think I really enjoyed. I learned a lot. Thank you very much for the nice presentation.
No,
Nice to see you also, madam.
I enjoyed your comments. I think they were very valid, and you're absolutely right. HCQ is something that we should just keep it as a, at the back of the mind.
Yes.
Mohit wanted me to talk about 2022. So I said at least something new I should talk about, because otherwise everything is the kind of same.
I think
So
I
I thought
that.
we should just have it. There was an IVIG trial also, with IVIG, immunoglobulins, which was negative. So I have kind of stopped showing it, although I myself is trying to do a trial on IVIG in these patients, but I think that something is so expensive that we don't even want to try that. But HCQ, I thought in some cases, it's a relatively safe drug. We've all used it during COVID times. Initially we used to use it as prophylaxis, 2 tablets every week and all that. So I thought it's back now. So I should talk about that.
I think what I said was the postgraduates or the faculty who has listened to this should take this up.
Yes.
And they should try.
Yes.
They should try along with steroids or relatively smaller dose and this thing, but should get clear ethical clearance before that.
Yes.
Because carditis in children could be fatal. So there should not be a setback for us. Okay.
Sure.
Thank you.
Sure.
Ma'am, this is Dr. Girish.
Hi.
Good evening, ma'am.
Good evening.
Ma'am, one small clarification which I would require, because we usually say that there is a characteristic response to salicylates for arthritis in acute rheumatic fever. Do you get such similar responses with naproxen and ibuprofen?
No. That's why I would use it for diagnosis. I mean, I've actually done it. Sometimes the patients are referred to us only for pain, joint, and there is no cardiac issues. And then, you can just try giving them aspirin. In fact, if you read the guidelines from American, they say don't use aspirin till you're sure about the diagnosis, because it wonderfully takes it away. But I often use it as even a diagnostic, because we see a lot of rheumatic fever than what Americans would see. So I have used it. But having said that, once I know that it is rheumatic fever, I still continue to use aspirin in much lower doses than what I have shown. And I think most of these patients do very well with even 50 mg per kg per day dose of aspirin. Yeah. But having this naproxen and brufen is something that is superior to aspirin is only the Australian guidelines. We still would use aspirin.
Between these two drugs, we have two different brands of aspirin coming in. One in 350, that is Disprin, and another one, Ecosprin, is 325. Which is better for children, ma'am?
I'm usually using Disprin. I'm usually advising them Disprin. Yeah.
I think because Disprin has citric acid also, along with, I think, one more component. So I'm not able to, because there are 3 components to that: acetyl-salicylic acid, then citric acid, and one more component in that. Whereas Ecosprin comes in only 325, but whereas Disprin comes in 350 milligrams.
I think I'm usually writing aspirin, and I see that most of the people are getting this. Some of them bring 100
Disprin.
milligram tablet also, which is so.
Colsprin. Yeah.
Colsprin. Yeah.
Ma'am, then 2022, we are asked that what are the mortality patterns with ARF, ma'am? So what would be answer? Generally, students are asked, and we say that in developed countries it's almost 0%. So what about India and Southeast Asian countries, or the countries where it is highly prevalent, ma'am?
See, unfortunately, we don't have data on mortality in acute rheumatic fever in developing countries. But my own experience is it's very rare. Majority of the patients as I said, we have only pushed 4 patients per surgery during all these, hundreds of patients that I have seen. And these obviously are the patients who would have died. And that was the reason why they were sent for surgery. But yes, we have sometimes lost patients in emergency. They come in such a sick state, or they are in a shock that you think that they are rheumatic fever, but you're not even sure. And then they die. But I think mortality is very rare, I would say, much rarer than, then of course Western countries is 0, but even our mortality is going to be much rarer in acute rheumatic. Yes, a lot of patients die of rheumatic heart disease. I mean, that is a huge number. Patients are coming with gross failure, not operated, and they die. But if we talk of acute rheumatic fever, it's not that high.
Second, ma'am, that it's very rightly mentioned in a couple of books also that the severity of carditis and severity of arthritis, they are contrary to each other. They are inversely proportional. So the more severe is the arthritis, lesser will be the chances. So once we know that the arthritis is generally 70 to 75% cases you have, this is a typical occurrence of arthritis. Carditis typically is 50 to 70, but if subclinical carditis is included, it's approximately 15 to 20%. So wouldn't it be more logical that carditis is actually the most commonest manifestation in this? If we take this clinical criteria.
I agree. I think, what is happening, Mohit, that patients that we are getting as cardiologists are filtered. So very few patients are coming to us who have clinically no murmur. Very few, because majority of them are being seen by the pediatrician. Only some of the patients where they are suspecting that there could be a murmur, or they want an echocardiography to be done, they will refer to us. So practically every patient that we see has carditis. But if you go by data which is published many years ago also, in 1980s and 90s, the carditis has been reported as 70%, 80%, even 90% in one of the studies. And as you said, if you take subclinical carditis, it will be almost 100%. So yes, polyarthritis is less common, carditis is perhaps more common, but those who have severe carditis perhaps will have very mild or no carditis. Those who have severe carditis will perhaps have very little polyarthritis.
And before we take a comment from Sudesh sir, he was saying something. I have a question, ma'am, because this is on the behalf of residents. Many of them have personally written that, they are repeatedly asked what is the incidence, what is the prevalence of rheumatic fever in this. Now, what happens is that whenever they are saying a particular value, the examiner is most of the time, almost 90% of the time, he's not pleased with the answer. So as a common examiner, because this is on, which are the 2 or 3 very important studies that they should be knowing that, pre-penicillin era, like pre-penicillin is 1944, this Bland Jones complete study. Then after that, what they should be knowing and what are the values that are generally acceptable in exam, generally, as in, because you have been a very, experienced examiner.
So this is actually quite a moving target.
Yes,
long time ago, if you see Dr. Padmavati's studies, which were done in 70s and early 80s, it used to be 11 per 1,000 rheumatic heart disease. The school studies, and those were not echocardiography; those were clinical studies. Then then you come to 2018, 2019, and you get 1 per 1,000 as the prevalence of rheumatic heart disease. Now, again, this echocardiography thing that has come up has been very confusing. And when the examiners ask, I think the postgraduates should answer it in 2 ways. Right now, you talk of clinical prevalence of rheumatic heart disease and echocardiographic prevalence of rheumatic heart disease. Now, again, we are not talking of ARF, we are talking of rheumatic heart disease, RHD. So when you say clinical prevalence, it may be 1 or even less than 1, because the data is almost around 1. But when it comes to echocardiographic prevalence, the data from our own country comes to about 7 or 8 per 1,000. So this is echocardiographic prevalence, but clinical prevalence will be 1 or even less than 1 in some. Again, the
7 to 8 per 1,000
per 1,000 children. Yes.
of RHD.
Yes, this
So,
is
ma'am,
echocardiographic data.
In 2011, your paper only, which was published in Heart, you remember?
20 as 20
it was
per
20 at
thousand.
that time.
Yes,
Yeah.
yes. So what had happened after that is, in fact, if you know, that World Heart Federation criteria came up in 2012.
Yeah.
So we had used different criteria. Now with standardization of 2012 criteria of World Heart Federation, lots of studies have been done, including our own multicentric studies that we published later, 2015 or 2016, I think, where we've studied in Ballabgarh, in Goa, in Maharashtra, and one more district, so Northeast. So we total overall was about 7 to 8, if I remember correctly, around 8 per thousand as the echocardiographic prevalence.
Published where, study. It was
published. This is published in IJC. This is called Extended Rheumatic Study, E-Rheumatic. That was Rheumatic. This is E-Rheumatic Study. It's a multi-center data of 4 centers in India. And I think they should know that, because then they can quote it. Because this is the latest data that we have within our country.
Yeah, that is right.
Yeah.
So that's you were saying something.
Nothing. The last part, I think we have studies from Velu. We have studies, ICMR study, largest number among the school children, which has come about 5 years back. The students should be familiar with that. Yeah. Then one more thing is not just what the students should read is AHA scientific statement of 2015, and the latest which came in 2020 by who was the chief person was Dr. Krishnuma.
Yes, sir.
He has given adequate, because we ask these things, and if they have not read these things, we will not be unhappy. Yes. They may quote something earlier. They also should know about these things. Scientific statement, which is very clear. Then Dr. Mohit was asking, they should know about the latent, subclinical, and clinical. These 3 things have been clearly defined. Now the incidence will be much higher because latent is also included. Echocardiogram criteria, we are too lenient. Those people who are doing echocardiogram and reporting, they are not following that criteria to say that this is significant amount. The most important thing, there should be a pansystolic or pandiastolic envelope in at least one this thing. All those things, nobody look into that. The thickness, everything is visual. I have nothing much to add, but they should read. They should read rheumatic fever, the standard textbook. They should the YouTube. This is loaded. They should listen to this. At least they should listen to it and make a note of that. What they do is YouTube, it is out. They should make a note of that. They should read the standard textbook where majority of the things are quoted, and at least the previous article, but definitely 3 things I'll quote. One is the 2015. Second is Dr. KK's, which came in 2020. And I'm also interested in that New Zealand data. New Zealand data gives very detailed this thing. It is very with clarity, but may not be applicable because it is their protocol for their population. But they should know that clear clarity in that article.
The Vellore one is of the Indian Heart Journal, you're saying?
Pardon?
The Vellore data is of the Indian Heart Journal, the one that was published?
Yeah, I think Dr. Vellore has a data. Then I think the other is the ICMR, which is the largest number, I think.
ICMR has published a multi-centric data.
Yeah, that's the largest number.
Yes, that's in lakhs and lakhs of children. And that actually has 2 or 3 parts to it, including the streptococcal sore throat prevalence, then prevalence of rheumatic heart disease. And then there is another data from Shimla, from Dr. Negi's group, which talks of the change that has happened over 1 decade. So they are comparing their data 1 decade earlier and 1 decade now. So I think there are 3 or 4 important data from India itself, which the students should be conversant with and quote with confidence.
Yeah, that's right.
I think that has been a terrific discussion, ma'am. There's no doubt. Always great to learn from you. We have been listened to this earlier, but every time you get to absorb so much new, and then so there's comments are always icing on the cake. So it was truly a pleasure. As a student, sitting in front of you, I'm very humbled, and I feel my colleagues and everybody would also be equally humbled and learning from such learned speakers and moderators. So with hands folded, I thank you so much for this joining us today on this academic platform. We'll continue this our academic saga, and this is for benefit of all of us. And I think this lecture you should discussions also you should re-listen, and I will also try to find all these articles and quote on different give you on different groups, and read this so that this particular topic is clear to you forever. So thank you so much, sir. Thank you so much, ma'am. Thank you, Girish. Thank you, everybody.
Thank you.
Thank you for providing this platform. Thank you so much. Gratitude. Thank you.
Thank you.